Good evening. So I'm here to discuss few recent MCQs. Basically, I've collected few MCQs from the latest NEET, that's NEET 2020 and INI-CET questions. Let's discuss question number 1. Lab reports of a patient is given below. Basically, the NEET 2020, the latest question paper had 2 questions on acid base. So I've clubbed both these together. The first question was lab reports of a patient is given below. pH was 7.2, PCO2 was 23 millimeters of mercury, bicarbonate 10 milliequivalents per liter. Diagnose the acid-base disorder. So whenever you're given such a question, you should begin with pH, right? So what is a normal pH? You know the normal pH is between 7.36 to 7.44. This is normal pH, and what you see here is a low pH. So pH less than 7.36 means it is acidosis, right? And what are the 2 causes of acidosis? Acidosis can be either because of a decrease in bicarbonate or it can be because of an increase in PCO2. Why does a decrease in bicarbonate cause acidosis? Simple reason, bicarbonate is a major plasma buffer. So if this plasma buffer is missing, all acids, all metabolic acids would accumulate in the circulation without being buffered. So that causes metabolic acidosis. Do you understand this? If acidosis is because of decrease in bicarbonate, it's called as metabolic acidosis. Acidosis, on the other hand, can be because of increase in PCO2. Reason is whenever carbon dioxide accumulates, it reacts with water to form H2CO3, and that dissociates to give H plus and bicarbonate. So this gives rise to a hydrogen ion. I know some of you have a doubt. Don't you see that an equimolar bicarbonate is also getting produced whenever carbon dioxide concentration increases? In that case, why do you call carbon dioxide as a source of acid alone? It's because the concentration of hydrogen ion and bicarbonate normally is different. What is a normal hydrogen ion concentration in your blood? For a pH of 7.4, expected hydrogen ion concentration is 40 nanomoles per liter. It is as low as 40 nanomoles per liter. Whereas bicarbonate concentration is normal is 24 milliequivalents per liter. This is in nanomole concentration. This is milliequivalent per liter concentration. So which concentration is the least? Hydrogen ion concentration is the least. And to such a low concentration of hydrogen ion, if you add 1 mole of acid again, the magnitude is going to be more. Though there is addition of 1 mole equally to both hydrogen ion and to bicarbonate, the effect will be multitudes. The effect will be in multitudes for hydrogen ion. That is why we consider carbon dioxide as a source of acid. Okay, so if it's because of an increase in PCO2, you call it as respiratory acidosis. So this is step number 1. I have not told you the actual step number 1, but listen to this for questions of this kind, which normally appears in NEET or in INI-CET. This is how you should approach the question. You first look at pH. Normal pH is between 7.36 and 7.44. If the pH is less, it's acidosis. Then it's your responsibility to find out if it's metabolic acidosis or respiratory acidosis, for which you look at bicarbonate concentration and PCO2 concentration. If a decrease in pH is accompanied by a decrease in bicarbonate, you call it as metabolic acidosis. Whereas if a decrease in pH is accompanied by an increase in PCO2, you call it as respiratory acidosis. Okay, let's look at this question. The pH here is less and you are looking at PCO2. PCO2 normally is 36 to 44 millimeters of mercury. You know that, right? Normal PCO2, we always say arterial partial pressure of carbon dioxide normally is 40 millimeters of mercury. And what do you observe here? There is a decrease in PCO2. Can this abnormality of PCO2 account for a decrease in pH? No. Only an increase in PCO2 can account for a decrease in pH. So this is not the cause. Now look at bicarbonate. What is a normal bicarbonate concentration? I said 24 milliequivalents per liter. On either side you can have 3. So the range is 21 to 27 milliequivalents per liter. Okay. And what do you find here? There is a decrease in bicarbonate. Can that explain the decrease in pH? Yes. So what is your diagnosis here? It is metabolic acidosis. Isn't that very simple? Yeah, this is metabolic acidosis. So step number 1 for such questions is looking at pH. Step number 2 is to find out whether it's a metabolic condition or a respiratory condition. Okay, now step number 3 is to check compensation. You have to find out if the compensation is adequate or if the compensation is not adequate. We call it as compensated metabolic acidosis, uncompensated metabolic acidosis, compensated respiratory acidosis, uncompensated respiratory acidosis. So for you to find out whether there is compensation, adequate compensation or not, we have various formulae. Okay, so I will tell you those formulae later. For now, what is the basis of compensation? The basis of compensation is whenever the primary defect is with bicarbonate. Yeah, if the primary defect is with bicarbonate, compensation will be done by PCO2. This is point number 1. Whenever the primary defect is bicarbonate, compensation will be done by PCO2. Point number 2 is the compensation will always be parallel. That is, if the primary defect is an increase in bicarbonate, compensation will be an increase in PCO2. Isn't that logical? If there is an increase in bicarbonate, you will call it as an alkalotic condition. And for alkalosis, what should be the compensation? You should produce an acid. And you know, carbon dioxide is a source of acid. So carbon dioxide should accumulate. Okay. If the primary defect is a decrease in bicarbonate, the compensation should be a decrease in PCO2. How does this happen? How can a decrease in bicarbonate cause a decrease in PCO2? How do you think a decrease in bicarbonate cause a decrease in PCO2? First tell me, what do you call this condition wherein there is decrease in bicarbonate as? Metabolic acidosis as, so if it's metabolic acidosis, you know, hydrogen ion accumulates in the circulation, that gets reflected in the CSF. What if it gets reflected in the CSF? Respiratory center gets stimulated. Yeah, the person hyperventilates. The person washes away, carbon dioxide, and that is the basis of Kussmaul's breathing, which happens in metabolic acidosis. And because of this Kussmaul's breathing, PCO2 is reduced. Do you understand this? So what are the 2 points you need to know? Based on the primary defect, if it's in bicarbonate, compensation will be in PCO2 and vice versa. Second fact is it's always parallel. Increase of bicarbonate will be accompanied by an increase in PCO2 and vice versa. Okay, so that's point number 2. Point number 3, which you should all remember, is if it's a metabolic disorder like metabolic acidosis or metabolic alkalosis, it is just one compensation. Do you understand this? If it's a metabolic disorder like metabolic acidosis or metabolic alkalosis, there is only one type of compensation. Whereas if it's respiratory acidosis or respiratory alkalosis, okay, if it's respiratory acidosis or respiratory alkalosis, there are 2 steps of compensation. One we call as acute compensation, the other one is a chronic compensation. Okay, the reason is if the primary defect is, say, respiratory acidosis, wherein PCO2 is elevated. Yeah, wherein PCO2 is elevated, there will be an acute compensation that happens in a matter of few hours. Okay, later kidneys come for the rescue. wherein what do kidneys do? They start reclaiming more and more bicarbonate. So there will be an acute compensation stage followed by a chronic compensation stage. Acute compensation happens in a matter of few hours, whereas chronic compensation happens in a matter of few days. Similarly, if there is a decrease in PCO2, again there will be acute and chronic compensation. And for all these compensation, we have a formula. Okay. First, let me tell you what is the compensation for metabolic acidosis. So, in metabolic acidosis, the primary defect is a decrease in bicarbonate, which should be compensated by a decrease in PCO2. When there is a decrease in PCO2, what is the expected PCO2? Expected PCO2 is equal to 1.5 into bicarbonate plus 8. Please memorize this formula. What is expected PCO2? It is 1.5 into bicarbonate plus 8. I'll give you an example. In a metabolic acidosis, you see that bicarbonate is 18. What is a normal bicarbonate? Tell me, what is a normal bicarbonate? 24. All of you try to answer this. Okay. Instead of 24, 21 to 27, instead of 24, the bicarbonate has reduced to 18. In that case, how much should the PCO2 be reduced? Expected PCO2 is equal to 1.5 into 18 plus 8. What is 1.5 into 18? Into 1 would be 18, and then a half. So, 18 plus 9 would be 27, plus 8 will be 35. Expected PCO2 is 35. Okay, I am going to tell you few scenarios and I want you to tell me the diagnosis. Expected PCO2 is 35, but in this arterial blood gas report, you see a PCO2 of 38. Yeah, the ABG chart or the ABG report tells you that the PCO2 in this case is 38. What is your diagnosis? What is your diagnosis? From 40, the exact compensation would have been, from 40, the exact compensation should have been 35. Instead of it being 35, it has reduced only to 38. So, what will you call it as? Very good. Uncompensated. It is uncompensated metabolic acidosis. This is scenario 1. Scenario 2, PCO2 is 35. PCO2 is 35. What is your diagnosis? If PCO2 is 35, you would say it is compensated metabolic acidosis. Now the third scenario, have a look at this. PCO2 is 30. Third scenario, PCO2 is 30. From 40, you expect it to be reduced to 35. In this condition, it's not even 35. It is reduced even further, which is 30. According to Shanmugapriya and Meghna, it is overcompensation. Can all of you answer? Do you think it's overcompensation? Your body never overcompensates. Do you understand this? Why will your body try to overcompensate? It will only try to compensate. When it tries, it either achieves or it does not achieve. So, very good. So, it is either uncompensated or compensated. And if you see it to be overcompensated, it means there is an additional acid-base disorder. Do you understand this? Which acid-base disorder could have caused a further decrease in PCO2? Which additional acid-base disorder could have caused a further reduction in PCO2? It is associated respiratory alkalosis. Okay, so why do you look for compensation? You look for compensation not just for you to find out whether it's compensated or not, but because only when you look for compensation, you will identify hidden acid-base disorders. Right? That is why you need to know all these formulae. So, what is the first formula I've told you? So, what is the first formula I told you? I told you the formula for compensation in metabolic acidosis. What is the formula? Expected PCO2 is equal to 1.5 into bicarbonate plus 8. Okay, now I am going to tell you the formula for metabolic alkalosis. For metabolic alkalosis, again expected PCO2 is equal to 0.9 into bicarbonate plus 16. Yeah, it is 0.9 into bicarbonate plus 16. For example, the actual bicarbonate concentration is 24. Instead, a person has got a bicarbonate concentration of 30. Yeah, so excess bicarbonate has caused alkalosis, that's called as metabolic alkalosis. In that case, what should happen to PCO2? That should also be elevated. How much should it be elevated? Substitute 30 here. 0.9 into 30 would be 27 plus 16 would be 43. So, expected PCO2 is 43. And if the actual PCO2 in that person is 41, what will be your answer? You expect it to be 43 from 40. If it's actually 41, what will be your answer? Yes, it is uncompensated metabolic alkalosis. Right, it's uncompensated metabolic alkalosis. If it's 43, what is your answer? Compensated metabolic alkalosis. Instead, if you see the PCO2 to be 50, yeah, if you see PCO2 to be 50, don't say it's overcompensated metabolic alkalosis. What will be your answer? It is an accompanied respiratory acidosis. It's a hidden respiratory acidosis. Okay, so that's about metabolic acidosis and metabolic alkalosis. Now, I am going to tell you for respiratory acidosis and respiratory alkalosis. In respiratory acidosis, for every 10 millimeter of mercury, increase in PCO2, bicarbonate will also be elevated by 1 milliequivalents per liter. Simple, right? For every 10 millimeter of mercury increase in PCO2, bicarbonate will also be elevated by 1 milliequivalent per liter. This is for acute compensation. I said for respiratory disorders, there is always an acute compensation and then a chronic compensation. And for chronic compensation, for every 10 millimeter of mercury increase in PCO2, bicarbonate will be increased by 3.5 milliequivalents per liter. Do you understand this? So, if it's an acute bronchial asthma, yeah, acute bronchial, say following exposure to an allergen, a person is presented with bronchial asthma. So, it's an acute condition. If it's an acute condition, how will you check for compensation? Bicarbonate is supposed to be elevated by 1 for every 10 millimeter increase in PCO2. Whereas, if it's a chronic condition, yeah, chronic condition leading on to carbon dioxide accumulation, say chronic obstructive lung disease. If it's chronic obstructive lung disease patient, a known patient of chronic obstructive lung disease, it should be a chronic compensation that you have to expect. So, it's elevated by 3.5 milliequivalents per liter. Okay, this is for respiratory acidosis. Now, respiratory alkalosis. Again, you have an acute compensation and a chronic compensation. How will you calculate acute compensation? For every 10 millimeter of mercury decrease in PCO2. Yeah, for every 10 millimeter of mercury decrease in PCO2, bicarbonate should also be reduced by 2 milliequivalents per liter. Bicarbonate should be reduced by 2 milliequivalents per liter. If it's chronic compensation, for every 10 millimeter of mercury decrease in PCO2, bicarbonate will be reduced by 5 milliequivalents per liter. I just remember it as 3.525. The first one is for respiratory acidosis, second one is for respiratory alkalosis. This is acute, this is chronic. This is acute, this is chronic. 3.525. Respiratory acidosis first and then respiratory alkalosis. So tell me, how do you check for compensation? For metabolic acidosis, the formula is 1.5 into bicarbonate plus 8. For metabolic alkalosis, the compensation is 0.9 into bicarbonate plus 16. Respiratory acidosis and respiratory alkalosis, there is acute and chronic compensation. For respiratory acidosis, it is 1 and 3.5. For respiratory alkalosis, it is 2 and 5. Are you clear? Yeah, if you know these steps, that would be more than enough for you to answer any question on ABG report. Yeah, so what is the first step when you are given an ABG report? You look for pH. Yeah, if it's less, it's acidosis. If it's high, it's alkalosis. And in both the conditions, be it less or high, the next thing that you will look for is bicarbonate and PCO2. Yeah, if an increase in pH, listen to this, if an increase in pH is accompanied by an increase in bicarbonate, what is your diagnosis? If increase in pH is accompanied by an increase in bicarbonate, what is your diagnosis? Very good. Metabolic alkalosis. If increase in pH is accompanied by a decrease in PCO2, what is your diagnosis? Respiratory alkalosis. So this is how you identify the primary disorder from pH. Okay. Now, does that mean if I say a normal pH, yeah, if I see a normal pH in an ABG report, can I safely say, okay, this person is in acid-base homeostasis? The pH is normal, so can I say this person has got perfect acid-base homeostasis? No. So normal pH does not mean the person has got perfect acid-base homeostasis. It can be a scenario wherein there is a combination of acid-base disorders. For example, it can be a combination of metabolic acidosis and metabolic alkalosis. Right? It can be a combination of metabolic acidosis plus respiratory alkalosis, or metabolic alkalosis plus respiratory acidosis. And which is the only combination that can never be found? I told you so many combinations, right? Metabolic acidosis, metabolic alkalosis, acidosis, respiratory alkalosis. So which combination is never possible? Yeah, respiratory acidosis plus respiratory alkalosis is never going to be the case. Other than this, every other acid-base disorder combination is possible. Okay, so even if the pH is normal, you go straight forward, you look for bicarbonate and PCO2. If there is abnormalities of bicarbonate and PCO2, then it means, yeah, what does it mean? It means the person is not in acid-base homeostasis. Okay, suppose I see a decreased bicarbonate, okay, normal pH, decreased bicarbonate, increased PCO2. Will you be able to make a diagnosis with these conditions, with these values? I've given you there is normal pH and then some abnormal value of bicarbonate and PCO2. For example, decreased bicarbonate and increase in PCO2. You say it's metabolic acidosis and respiratory acidosis. You won't be able to find out what is the primary defect in such scenarios. That is why we look at something called as bicarbonate yes value. We have two values of bicarbonate about which I'll tell you in the next week's session. For now, let's discuss what happens when there is low pH, what happens when there is high pH. Normal pH I'll tell you in the next session. Okay. So you have identified the primary disorder. So after you identify the primary disorder, the next step is looking for compensation to find out if there are hidden disorders. So for compensation, we have formulae. We have a formula for metabolic acidosis, metabolic alkalosis, respiratory acidosis, respiratory alkalosis. Whenever you find an overcompensation state, it means there is a hidden disorder. Okay. So with these three steps, you will be able to make a diagnosis of most of the arterial blood gas reports. So what is your diagnosis here? Decrease in pH is accompanied by a decrease in bicarbonate. So the answer is Metabolic acidosis. Answer is choice A. Okay. Now another question on ABG in the same NEET 2020.